Welcome to This Week in Critical Care. This week, we're covering 10 notable papers spanning advanced respiratory and extracorporeal support, pharmacological and metabolic optimization, and the critical intersection of ICU ethics, delirium, and neuroprotection. Let's dive in. We begin this week with a deep dive into advanced respiratory care and extracorporeal life support, starting with a comprehensive review in intensive care medicine that looks back at 60 years of positive end expiratory pressure, or PEEP, in the management of acute respiratory distress syndrome. The authors emphasize that the clinical response to PEEP is highly individual, representing a delicate patient-specific balance between alveolar recruitment and alveolar overdistension. The paper suggests a clear, physiologically grounded framework. Patients with a PaO2 to FiO2 ratio greater than 200 millimeters of mercury are highly unlikely to have substantial recruitable alveolar collapse. For these patients, clinicians should avoid high PEEP and instead use a lower range of 5 to 8 centimeters of water, which helps facilitate a smoother transition to assisted ventilation. Conversely, for patients with a ratio of 200 or less, higher PEEP is more likely to be beneficial, but its titration must be guided by an assessment of lung recruitability using tools like computed tomography or gas recruitment indices. When significant recruitability is confirmed, PEEP titration should integrate global mechanics like plateau pressure and stress index with regional monitoring, such as electrical impedance tomography or transpulmonary pressure. This nuanced approach to lung protection is mirrored in a review from the American Journal of Respiratory and Critical Care Medicine, focusing on the physiological mechanisms of extracorporeal life support, or ECLS. The authors outline how respiratory ECLS stabilizes gas exchange and modulates respiratory drive, which directly enables lung protective ventilation and attenuates both ventilator-induced and patient self-inflicted lung injury. By interrupting the dangerous cycle of hypoxemia, hypercapnia, pulmonary vasoconstriction, and right ventricular overload, ECLS facilitates multi-organ recovery. However, the review notes that achieving these benefits requires a sophisticated understanding of circuit-patient interactions to avoid device-related complications and inflammatory perturbations. Finally, we look at a highly prevalent but often overlooked mechanical obstacle in obstructive lung disease: airway mucus plugs. A review in the American Journal of Respiratory and Critical Care Medicine highlights that mucus plug burden, which can be quantified using computed tomography scoring systems, is a key driver of frequent exacerbations, rapid spirometric decline, and increased mortality in both asthma and chronic obstructive pulmonary disease. Recent clinical trials using biologic therapies have demonstrated that mucus plug burden can be reduced, leading to corresponding improvements in lung function. The authors argue that mucus plugs should now be viewed as a highly treatable clinical trait, and they advocate for the widespread clinical and research adoption of computed tomography-detected mucus plug scoring to guide targeted therapies. Turning our attention to pharmacology and metabolic management in the ICU, we first examine how we administer critical medications. A network meta-analysis of 35 randomized controlled trials involving over 10,000 patients compared the efficacy and safety of extended versus continuous infusions of beta-lactam antibiotics for severe infections. The analysis revealed that while neither prolonged strategy showed a statistically significant difference in all-cause mortality compared to traditional intermittent boluses, both extended and continuous infusions significantly improved clinical cure rates. Interestingly, indirect evidence ranked extended infusions, typically lasting 2 to 4 hours, as the top strategy for clinical cure and hospital length of stay reduction, while continuous 24-hour infusions ranked highest for microbiological success. Given its superior practical feasibility and nursing workflow advantages, the authors suggest that extended infusion is currently the most favorable option for clinical practice, though head-to-head trials are still needed to confirm this directly. Moving from antimicrobial delivery to organ protection, another major publication in critical care investigated the real-world implementation of the kidney disease, improving global outcomes, or KDIGO, kidney protection strategy in critically ill patients with moderate to severe acute kidney injury. In this multi-center prospective cohort study of 258 patients across 5 European centers, the researchers found a disappointing reality. The complete kidney protection strategy was implemented in only about 31% of patients. Among the individual components, optimization of mean arterial pressure above 65 millimeters of mercury had the lowest adherence rate at just 33%. However, the clinical impact of adhering to this bundle was striking. Full adherence to the kidney protection strategy was independently associated with a massive six-fold increase in the rate of renal recovery at hospital discharge, alongside a significantly lower risk of requiring renal replacement therapy within 30 days. The study demonstrated a clear dose-response relationship, where implementing a higher number of individual bundle components directly correlated with superior renal outcomes, making a strong case for strict, protocolized adherence in daily practice. In contrast, another common ICU intervention, red blood cell transfusion, was scrutinized in a retrospective study in critical care to see if mixed venous oxygen saturation, or SVO2, can serve as a reliable physiological guide. Evaluating over 1,300 cardiovascular surgical ICU patients, the researchers found that while a lower pre-transfusion SVO2 was associated with a higher likelihood of an individual-level SVO2 increase after transfusion, the overall cohort experienced an almost negligible change in mean SVO2. The authors identified an exploratory pre-transfusion SVO2 cutoff of 69% to predict an acute rise, but they strongly caution that this association does not establish improved tissue oxygenation or clinical benefit. Consequently, they advise clinicians not to use SVO2 or this 69% threshold as an active transfusion trigger. Lastly, in the realm of ICU nutrition, the Progress ICU study published in Critical Care explored whether guiding protein dosing by a patient's fat-free mass, measured via bioelectrical impedance, improves outcomes compared to standard dosing based on total body weight. In this before and after study of 620 patients, fat-free mass-guided dosing did not lead to a significant difference in 90-day mortality. However, it was associated with a shorter ICU stay, fewer days on mechanical ventilation, and less muscle mass loss over time. While these findings are promising, the authors urge caution due to substantial baseline differences between the cohorts, including a much higher rate of COVID-19 admissions in the weight-based group, and they call for definitive randomized controlled trials to confirm these metabolic benefits. Our final theme this week focuses on neurological protection, patient-centered care, and clinical ethics in the ICU. We begin with a review in intensive care medicine addressing how to optimize brain perfusion and prevent secondary cerebral complications in patients undergoing extracorporeal life support. Acute brain injury is a devastating and common complication during both veno-arterial and veno-venous extracorporeal membrane oxygenation, driven by a complex interplay of pre-existing injuries, cannula-related flow dynamics, and systemic physiological shifts. To mitigate this, the authors provide a practical framework focused on optimizing modifiable parameters, including the careful titration of extracorporeal blood flow, maintaining strict blood pressure targets, managing sweep gas flow to avoid rapid changes in carbon dioxide, controlling temperature, and maintaining precise anticoagulation. They advocate for the routine use of standardized, multimodal neuromonitoring to detect early signs of neurologic compromise and to guide patient-specific adjustments. This focus on protecting the brain and preventing cognitive dysfunction is closely aligned with a prospective study in critical care that evaluated a structured, nurse-led family participatory support intervention. In this trial, which utilized propensity score matching to compare 730 critically ill patients, trained family members participated in basic daily care under the close guidance of ICU nurses. The results were highly encouraging. The family participation group experienced a significant reduction in the incidence of delirium, down to roughly 27%, compared to over 34% in the usual care group. Furthermore, patients in the family participation arm had significantly shorter durations of mechanical ventilation, shorter ICU and hospital stays, and lower overall hospitalization costs, all without any increase in adverse events, accidental line pullouts, or ICU-acquired infections. This highlights family-centered care as a highly effective, safe, and low-cost non-pharmacological strategy. Finally, we must examine the ethical and demographic factors that influence our clinical decisions. A nationwide cohort study of over 650,000 ICU stays in Switzerland investigated sex differences in the timing and nature of decisions to limit life-sustaining treatment. The researchers discovered that women were significantly more likely than men to have treatment limitations, such as ceiling of care decisions, documented right at the time of ICU admission, with an adjusted odds ratio of 1.26. Interestingly, for patients admitted without any prior limitations, the rate of new limitations decided during the ICU stay was identical between men and women. The study also revealed qualitative differences. Women more frequently had documented personal wishes and ceiling of care decisions, whereas men were more likely to undergo active withdrawal of therapies based on physician-driven decisions. The authors suggest these early discrepancies may reflect deep-seated societal norms in advanced care planning, or potentially implicit clinical biases and heuristics used during prognostic uncertainty at triage. To ensure equitable care, they recommend that clinicians implement highly structured objective goals of care discussions immediately upon ICU admission for all patients. If you only have time for one paper this week, make it the Multicenter Perspective Cohort Study on the KDIGO Kidney Protection Strategy by Sajati and colleagues in critical care. This paper delivers an essential wake-up call by showing that we only fully implement these guidelines in about 1/3 of our high-risk patients, while simultaneously proving that complete protocol adherence yields an incredibly robust, 6-fold increase in renal recovery at hospital discharge. Here are the key takeaways from this week in critical care. First, for patients with acute respiratory distress syndrome and a PaO2 to FiO2 ratio greater than 200, avoid high PEEP and target a lower range of 5 to 8 centimeters of water to facilitate weaning, while reserving higher PEEP titration for those with demonstrated lung recruitability. Second, make protocolized adherence to the KDIGO Kidney Protection Strategy a clinical priority for patients with moderate to severe acute kidney injury, as full adherence is strongly linked to improved renal recovery and a reduced need for renal replacement therapy. Third, when administering beta-lactam antibiotics for severe infections, utilize prolonged infusions. Extended infusions of 2 to 4 hours offer a highly practical and effective option that improves clinical cure rates compared to traditional intermittent boluses. Fourth, incorporate trained family members into daily care routines through structured, nurse-led family participatory programs to safely and effectively reduce ICU delirium and shorten mechanical ventilation and hospital stay. Finally, remain vigilant to potential sex differences in early triage. Women are more likely to have treatment limitations documented at ICU admission, suggesting we need more structured and standardized goal of care discussions to ensure equitable care. That's your roundup for this week in critical care. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence which can make mistakes. Always review the original source materials.